Good afternoon, everyone. My name is Jackie Lizer. I'm a senior manager here at CAQH Core, and I'm really excited to welcome you to our webinar today. Core recently published updates to our eligibility and benefits data content rule, and today we'll be sharing with you what those updates are, what they mean for industry, and we're also welcoming a bunch of wonderful panelists who helped develop the rule who will have a thought-out discussion about these topics. Before we get into the agenda for the day, I'm going to run through some brief webinar logistics. Today's session is being recorded, so any attendee or registrant will receive a link via email to the recording after the webinar. While attendees' microphones will be muted during the webinar, we do encourage that you ask questions throughout. So if you have a question, you can communicate that by using that panel at the bottom of your Zoom screen, clicking on that Q&A feature and submitting them to any of our panelists at any time. We should have about 5 minutes at the end to address some of your questions. On the next slide, I'm going to have our panelists introduce themselves. We're really excited to have them here today. They crafted the rule in collaboration with us, and we're really excited to hear their thoughts on the process and the outcome. So starting with Rebecca, I'll have you introduce yourself first.
Sure. Hi, everyone. Rebecca Fien. I'm the Director for Dental Benefits Coding and Data Exchange at the ADA. I'm super happy to be here and represent the dental provider point of view on the changes.
Thanks, Rebecca. Christina?
Good afternoon, Christina Stees. I am with Emeritus Dental Insurance and also a part of the Indetic Eligibility and Benefits Work Group.
Thanks, Christina. Laura?
Hi, good afternoon, everyone. I'm Laura Toper. I'm president of Granada Health, and I'm here today representing NCPDP, so bringing that pharmacy and prescribing perspective to the discussion.
Great. Thank you all so much. I'm going to briefly go over our agenda. Before we get started, we'll have Bob Bowman from CAQH do a quick overview on CAQH and Core for those who might be newer to us as an organization. And then we'll have him do an updated Core eligibility and benefits data content rule requirement overview. So we'll let you all know what the requirements look like, how they compare to what our existing rule previous version looks like, and what those benefits are to industry. We'll open it up then to have a discussion with our panelists who we just met. They'll be covering some key changes and impact of the updates, implementation strategy, what the stakeholder experience looks like for different types of stakeholders, and some key takeaways and recommendations for everyone. We'll wrap things up with an audience Q&A and a brief call to action. And with that, I'll pass things over to Bob to get us started.
Great, thank you. Good afternoon. And just as Jackie mentioned, we do want to provide just a quick update and overview of who CAQH and what CORE is, as that initiative under CAQH, and then how the details of some of the edits and changes and revisions that we made to the operating rules related to the eligibility transaction. On the next slide, you'll see that CAQH is an organization that has many types of initiatives. Some of these initiatives, like our CAQH solutions, are related to product offerings that reduce cost, streamline different experiences that providers or members may have, and really put care back into the center of that mix. So who is that patient? What can we do better for that patient and serving them with the best providers, for example, or ensuring that the revenue cycle is managed most efficiently for that member. We also have an initiative like CAQH Insights, which publishes an annual index of findings of how the industry is migrating to more automated, simplified solutions to ensure that data exchange takes place again most efficiently. And lastly, CAQH Core, the initiative we're going to talk about today in detail, is related to bringing the industry together and developing operating rules for industry, mostly around administrative transactions based in the revenue cycle to help support, again, that data exchange that's really important to ensuring accuracy, confidence in the data, and real-time data exchange. On the next slide, you'll see that CAQH Core, the Core initiative, has over 100 different multi-stakeholder organizations are part of this group where we have been working for a number of years now. At the end of the year will be our 20th anniversary, if you can imagine, where we have have over those 20 years have published numbers of different sets of operating rules for the industry to consume and implement and bring savings to the industry because they're automating those systems, they're automating those solutions, those applications. Members don't have to necessarily bring their ID card with them every time they go into the office because the provider is confident in the data that they have. They can share that with an eligibility validation, verification check. There's lots of different vocabulary around that expression, but they can get that data back on exactly what those benefits are for that member. Again, this kind of cost savings is saving the industry billions of dollars in cost avoidance and cost savings, simplifying those interactions that a provider has with the health plan. On the next slide, you'll see that CORE is developed and developing operating rules no matter where you're at in the revenue cycle, whether it's today's example for eligibility and benefits, all the way down to benefit and enrollment, premium payment, claims, claim status, prior authorization. You'll find sets of operating rules in these spaces for health plans, providers, vendors, and clearinghouses to consume and use and build better applications so that those necessary business rules and guidelines are embedded within the software, embedded within the applications. So it's a one press of a button and you'll receive the data in real time. Really that API-driven data exchange is really the basis of the core operating rules. Today's focus, however, is on the eligibility transaction and the recent updates that we made. So as we transition over to the next slide, you'll see that as our focus, we have had some interesting updates, both from our index findings from last year. Again, this was recently published this spring, where even though the eligibility transaction is one of the most highly converted transaction to fully electronic transactions, even those 4 or 5% for medical or 15% for dental, if we can remove those from those web portal-based transactions, manual data entry, to a fully automated API-driven approach, we can save literally billions of dollars in the industry for medical and hundreds of millions for the dental industry because providers take a lot of time to manually work those transactions through their own applications at their office through to either the clearinghouses or to the health plan. So it takes a lot of time to do this. And it's very expensive to do that, both from the provider perspective, as well as the health plan perspective. There's lots of work that takes place behind the scenes to make sure that those systems and applications are updated and ensure that they're working efficiently. But if we can completely automate this, it really does reduce those costs and makes a lot of savings for the industry. If we can go on to the next slide, you'll see that we have completed the formal voting process for this update. So it has gone from our subgroups and task groups have completed their work. We worked with the industry, you on the phone or on the webinar this afternoon. You've put in your feedback. You've completed straw polls, which we were famous for, to getting really that granular level of detail that we need to ensure that the requirements really do justify the effort that the systems and application designers and health plans and vendors will have to do to make sure they can meet these requirements. It then moved over to the work groups where 60% of the organizations have to meet with over a 50% support rate for that vote or ballot. Then moved into our full core voting membership, again, where we still have to have that high level of quorum participation with an even higher level rate of approval. Again, makes it challenging for the industry because oftentimes that tension between providers and health plans with we need all this data and health plans have the struggle of making sure that this data is presentable to the providers and those applications that they use through their vendors available because it does take a lot of time, energy, and effort to do that. But again, we did achieve that level of support and quorum requirements at the full voting membership level. And finally, the updates went to our core board, and when the core board also voted to approve these rules. So you'll see now that the rules have been updated to our website, so they are officially adopted under core. So our core participants will continue to work through meeting their obligations as a core participant in adopting those rules within their own systems and applications. So you'll see, as we normally do, vendors are probably going to be the first out of the gate to adopt these because they can then sell their products better to their provider community or to the health plan community. then health plans will be adopting these rules as well. So trying to think of, not only do we have a voting process here, but we also have an implementation process that takes place now, right? Vendors are jumping into this space now to build these applications, and health plans are building out the databases to make sure this data can be shared with those vendors and those providers. To understand exactly the reach that this has in the industry and what we've done together collectively as CORE, on the next slide, you'll see that we had lots of participants really working hard to do this. And again, as Jackie mentioned, we had the ADA, NDETIC, and NCPDP. They actually came to us at CAQH Core and asked, hey, we're experiencing lots of trouble with these types of transactions related to our kind of specific lines of business. Can you help us? So we stacked hands, worked together, brought the rest of our membership together to work on ensuring that, again, those types of requirements are clear, concise, easy to compute and put them into systems and applications, making sure that the data is available. Because, again, this does take a lot of effort from all of these technology companies. So we did have leading health plans, lots of provider organizations, vendors that are going to be doing the work initially. But again, health plans and providers have to then implement it as well. And also important too is that there were standards development organizations and advisory groups that also supported this work. So this includes a lot of different organizations you may know, like NCPDP, X12, HL7, AMA, MGMA, those types of organizations that have wide participating bodies also work to help ensure that the rule requirements meet industry need. Now, getting into the detail of the operating rule requirements, on the next slide, you'll see that we had a great foundation with our initial version, right? That Eligibility 2.0. Again, it has very specific requirements for service type codes. There are requirements, even in that early version that dates back like 5 years now, for procedure code level inquiries. So very specific, those CPTs, those HCPCS codes can come in from the provider for physical therapy, occupational therapy, surgery, and imaging, those 4 categories of service. The provider can key in those codes and get a response back. What we really have done is expanded that into this next level for the eligibility version 2.1 to expand those types of benefits that are required to be supported for those categories of service. Many of these categories include dental and pharmacy or medications on that medical benefit. We'll get in more into that detail in just a moment. Those types of granular level detail that a provider needs to ensure the benefits of that member at the time of service. Remember, the patient is in the office. The provider is trying to render care. How much is this particular medication going to cost? How much is this particular dental procedure going to be an out-of-pocket expense for that member or for that patient? It allows for that provider to have a direct dialogue with the patient in the office right when the care is to be delivered. This makes for a great dialogue that can take place and a good understanding of what those benefits are, right? Remember, the member has a benefit with their insurance company. The insurance company has the data, can share it with the provider so that all 3 can have a really great dialogue about the level of care. Again, many of the original components of the earlier version also will still be maintained in this newer version. So the specialty health plans names, patient financial responsibility, copay, co-insurance, how much is this on your deductible, tiered benefits, if that's the case, both for the patient and the provider, and also that prior authorization determination. Does this particular procedure code or CPT code require a prior authorization? So the provider can know exactly then during the eligibility transaction if a PA is required. It doesn't have to go look on a manual website or go look to a web portal to key in something different to understand that. It can all be done there at the eligibility transaction. Makes it really a powerful tool. Getting down into the next slide, there's really specific details. We'll go through all of these, but just make sure that you understand that giving this granular level of detail, expanding those STC codes, for example, ensuring that more HCPCS categories of service codes at the National Drug Code level, at the CDT level, at the ICD-10 level, continuing with HCPCS and CPTs, getting down to that levels really helps ensure that the provider, again, can not only have that informed discussion with the patient, can and really understand what benefits are covered, prior authorization requirements that might exist, really makes it an improved care coordination, again, between the patient and the provider. What's really important here too, again, as we mentioned, we worked closely with Endetic and with the ADA on some of these really specific dental level benefits. So again, moving into that kind of really often siloed part of our industry for dental and for pharmacy really helps kind of unify some of that system data exchange networks that take place, what providers need at the time of service, and helps really ensure that, again, the provider has the information they need. And last but not least, we do have some requirements around policy accessibility. We don't want providers to have to hunt and peck all over the 12 different websites for the health plans that they bill on a typical day to find information. Um, uh, but if they have to, we want to make sure that it is available on the website, that it isn't something they have to go pull a manual contract to understand what the payments are, what the benefits are for this particular type of patient, because this patient might have access platinum, this one has access premium, this one has access gold, or what's the different level of benefits in each one of those. Making sure that all of those are available online so they can be accessed by the provider makes a big difference too. At a glance on the next slide, you'll see the whole host of the codes. Again, we won't go into all of the detail here, but to ensure that you can understand that at the procedure code level, the categories of service, at the service type codes, adding all of this data available in the eligibility transaction really extends and expands the requirements, not only the health plans and the vendors to support, but really as tools for the provider to get that granular level of detail that they need to perform those types of procedures and have those care coordination meetings with their members. Last but not least, we understand that there's several benefits, and we'll get into that during our discussion today, but maybe as a jump off a level set for what we can anticipate in our panel discussion. There's a number of benefits we think that CORE has formalized in adopting this rule. So on the next slide, you'll see that this helps empower the patient. The patients can gain control over their healthcare delivery and a cost upfront. They'll know exactly what this copay is, what the impact of coinsurance is, how this hits their deductible, what's the remaining deductible. All of that can really help. It focuses care, right? The provider can actually conduct care and care delivery more effectively because they'll have that data immediately. They don't have to wait, schedule another follow-up meeting or actual procedure with the patient because they didn't have the information when they initially could have had it in that first meeting. Improves patient management. Again, you can actually manage the care better. You can deliver care more efficiently, more timely. Again, modernizing the dental care experience is also really important, especially as dental care has changed in the types of procedures that are now available for those types of coverages. Those benefit models and those contracts change quite a bit. It's not just the new types of procedures and technologies that impact the potential for care delivery, but how does that actually impact the benefits and the benefit structures that those patients have? Again, ensuring that those price transparency and understanding costs and benefits for both the providers and the members, it really helps build that trust. So I've rattled off for the last 10 minutes or so. So I'm going to open up our panel discussion. And we have I guess we'll pull everyone up on the screen so you can see us as we have our discussion this afternoon. And what we'll do is we have a few series of questions that we like to ask. And again, please, if you have any other questions, please enter those in. We'll try to address those as soon as we can as well. And we did get some questions through our registration process. So we'll also have some of those to fill in too. So again, welcome back, panel, for our discussion. I'm going to open it up with a couple of questions. What do you see in each of your spaces that you're in as some of the most impactful edits or changes to the rule that we have today? And maybe I'll start with Rebecca. I saw your face first. So Rebecca, what do you think is going to be the most impactful?
Yeah, so I think the move towards procedure level responses is huge for dental. We have such unusual plan design. Service type code just doesn't get us the discrete information that is needed to really to figure out what is covered or what isn't covered. You can run a diagnostic service type code and get yes, no coverage. But at the procedure level, we're going to have things like bite wings that might have a different frequency allowed than say a pano or something more like that. They're all categorized in similar service type codes. So this is going to provide just a more trust in the responses that are going to be coming into the offices.
And Christina, thoughts on this question as well?
Yes, I agree. Definitely the expanded procedure level detail, but also coordination of benefits. When a patient is going in, maybe they're having some oral surgery, some of that's covered under their medical and also dental. I mean, it's the cost transparency. So this is what my medical is going to cover. This is what my dental plan is going to cover. And that I think is it's huge. It helps not only the member, the patient, but also, the carrier as well. It is a great win.
Great, great. And Laura, coming from that perspective of NCPDP, where the pharmacy and the prescriber, how does this impact?
I think, similar to what Christina and Rebecca said, the price transparency is important because right now, for your outpatient medications, if you will, the things you go to the pharmacy and take at home, the prescriber can find out what that cost for you is going to be before they send the prescription. Knowing for medications that are administered in the office, which tend to be more expensive, having that information before the medication is ordered and administered so that the patient understands what their cost is going to be, I think is huge. And that experience of it doesn't matter where I get the medication, I want to know what my cost is going to be, what my coverage level is going to be before I start that therapy.
Right, right. The cost is so important for a member, right? We are all members in reality, right? So for us to understand that cost is really important. Another thing, since we alluded to this through part of the discussion too, that adding this discrete level of detail or data, today it might not exist in that eligibility file that health plans and carriers publish today for their vendors or clearinghouses to kind of bang away on. So this is going to be an edit. This could be a change for them, right? They'll have to go through the typical software remediation, assign resources, cost. What's the best plan for that to take place? Maybe I'll jump back to Rebecca. Is the ADA working with dental health plans to get them ready for this? What are they going to have to do?
Yeah, so we've talked a little bit to some of our plan, through our relationships with the plans to talk about this is coming and why we thought it was necessary. Certainly education is going to be really, really essential here. But I think what we're hearing from those plans back is that they actually see this as advantageous. While there is a level of effort to move this forward, and it will take some resources on there, and the cutting down of the duplication of effort, the number of inquiries that are coming in, there's avoiding those bots that may or may not have the authority to be there, placed there, that are doing the queries as it stands now. I think this will streamline the efforts and actually reduce resources in the long run.
And Christina, staying on that dental, your work at Indedic is really important for the vendors that support dental health plans and dental providers. I assume that there's going to be an education effort there as well, and working with the vendors in this space.
Yes, absolutely. Just sharing that and also just so their teams are aware of the change and also, to get ready, right? Because it does take resources, right? EDI teams, need to start their code and get ready. So definitely, yes, Indedic will inform all of our members.
Perfect. And Laura, I know that as NCPDP, this will have an impact, but oftentimes this will be on the medical side of the house when it comes to the benefits. So the medical health plans will be having to make these updates and edits. What do you think will be some of the challenges that they'll face and kind of cracking open the detail behind these medication benefits?
I mean, I think it is going to be in that nitty-gritty detail of crosswalking the drug files. So the health plans may have the compendia files with the National Drug Code. The request from the provider may come in with a J code, so doing those crosswalks. As we move further in interoperability, it may be RX norm codes. And so those are all things the health plans are going to have to do. There's also going to have to be that coordination with whoever's processing their pharmacy claims, because the provider may initially do a real-time benefit check under pharmacy to figure out, is the product covered under the pharmacy benefit or not? And so the plan and the pharmacy benefit are going to have to coordinate to say, I'm covering these drugs in the office, you're covering these drugs through the specialty pharmacy on an outpatient basis.
I think that's a really good distinction in that, and part of the challenges, I think, of why this came to CAQH was that the pharmacy prescribers, the pharmacy is trying to figure out, okay, where's the benefit actually lie? Is it here in this, or is it here over here? And it's not clear, right? So that
Right.
when it's not clear, that impacts both the pharmacist as well as the member, because it's going to mean
Exactly.
delay because they then
And
have
we
to
had
figure it out, right?
Right, and that was really the genesis behind a white paper we published a few years ago, and why we came to CAQH to say there's so much duplicative work going on because the provider's office is trying to figure out, most often on those specialty medications, where is it covered? Where is it available to the patient? Can they get it and administer it at home? Do I have to order it and administer it in the office? Do I have to arrange nursing services? All of those things.
I think this part of the discussion is also hitting on perhaps a positive or improves the provider experience. Are there other
Absolutely.
things that like the requirements will help improve the provider in that experience, Laura?
I think it will save them some of that aggravation of sending a prescription somewhere only to find out that the pharmacy can't fill it because it's not covered under the pharmacy benefit. So it improves time to treatment, which improves, outcomes with quality measures. So it impacts the member patient as well as the provider and the provider staff if they get information back on that inquiry to understand that not only is it covered under the medical benefit, but prior authorization is required, they can start that process sooner.
Yep. Yep. So lots of, again, just little pieces of data, making it available for the provider. Again, whether it's a dental provider, the medical provider, or the pharmacist, making it available as soon as possible in that process, all the way up in the eligibility transaction, can really change kind of like the life cycle of that experience that the member is having. Um,
Exactly.
and Rebecca and Christina, I think that that experience can also be impactful for dental providers and dental patients as well, right?
Right, absolutely.
Yeah, absolutely. I think one of the hardest things for a dental provider in their office is when they say, "Oh, here's your treatment plan. This is what I think you need," and then when they run, eligibility, and they try to present, you know, this is what you're gonna owe, and they're like, "This is kind of the best guess until we actually get to submitting the claim." Unfortunately, because dental is such a limited benefit, usually you have a pool of money that you're working with. It's first come, first serve in that benefit a lot of times. So getting closer to real-time eligibility, real-time benefit information is so critical for our industry. It's actually just a huge benefit in that provider-patient relationship.
Right. And you mentioned something that kind of strikes me as like price transparency and understanding the cost for the patient, right? Is it really going to cost me $500 for the service, or is it really 1,200? And if you don't know, that's a big difference for the financial impact for that patient. And also for the provider, right? They don't want to perform the service and know that the reimbursement is going to be this much when they anticipated this much, right? So that cost and the payment model, both for dental and for pharmacy and medical for that matter, although different, can be really impactful for the patient. So these edits or changes that we're making to the rules seems to have an impact on price transparency. Would you all agree?
Agree.
Absolutely. And I think if you look at the recent RFI that was comments closed a couple of weeks ago on improving the patient experience and leveraging technology, this falls into that as well as we move again more towards interoperable solutions and having information available to coordinate care, improve price transparency, all of those things we've been talking about. I think this is just a critical step that, I'm looking forward to seeing people start to implement to achieve those goals.
Yeah. Yep. Um, it's a good question. I think that leads me to another question, right? The implementation and the resourcing that it's going to be required to do this. I think we can all agree it's not going to be an easy lift, right? Anytime that you have to change a database, wherever that database may reside, will take energy, resourcing, timing, scheduling, get that approved through whatever process those plans or vendors have to get this in. Um, what I don't know. How bad do you think this is for these health plans that you work with every day? Is it maybe a low, medium, high level of effort? Could we maybe estimate?
Yeah, I would say it kind of depends too how robust their, 271 transaction is today, Bob. But
Yeah.
I would say it could be, medium size,
Mhm.
or could be large. Maybe they don't, have some of those elements in the 271 today. So I think it all kind of depends, on that carrier, and also the team on what they have available today. And,
Yeah.
maybe it will be low because maybe a lot of them are already providing this detail in the 271 transaction.
I know we've got, I know I'm kind of jumping a little bit on the agenda, but we have a great question that came in from the audience, kind of related to this. So I want to bring it up now. And it's health plans are only required to do what they need to do to be compliant. And this seems to be a step above and beyond the mandated version. I'm going to take the first swipe at that, but I'll give you guys a moment to think about that. Um, Completely correct. Health plans and other HIPAA covered entities are only required to do what's required to be compliant. What's amazing with the core operating rules is that this is still compliant, right? We've come together, these organizations that you see on screen right now, have come together to flip on some of those extra levers that are still within the mandated compliant version of the transaction. The procedure codes are allowed in the 270 transaction to come in. So it's really the implementation on the back end at the health plans and the vendors that have maybe cut off that lever. They've never turned it on. The operating rules are actually allowing this to come in now, requiring it if you're going to be core certified. And health plans can turn on that data that's in those systems, right? We know it's in the claims adjudication system. That's the only way you can adjudicate a claim, right? You have to have the procedure code. So if you move some of this data into the benefit structure, then the health plan can respond with the information related to the benefits for that procedure code or that CDD code for this example for dental. So it makes it really helpful. So yes, it's going above and beyond maybe the basic implementation. I think, Christine, you brought that up too in your response just a moment ago, that it depends on how you've implemented the standard. If you have a really light touch implementation, it might be a really big level of effort for you. But if you have been looking at your provider community and your member community and seeing what their needs are over the years, I mean, making tweaks and updates and allowing these things, then you might not have as much of a lift to meet these requirements. I'm going to pause there and get a reaction from our panel.
Yeah, I mean, I can share from the ADA's perspective. We see this as um, it's the right thing to do first. If you look at, I mean, I love the index report because it just for this transaction, the amount of money that the inability to automate this transaction costs the dental industry is outrageous, and that money could be going to other things. So for the ADA, we see this as essential, and it's something that we have an advocacy stance on. Yes, I think it's really important that this is sort of harmonized with what we're at with the transaction. But it's the step in the right direction. And so we as an industry kind of just have to say it might be painful, but we're going to do it because it's the right thing to do.
Laura, response or thoughts on how this can be positively impactful and maybe costly to do?
Well, and I mean, I agree. I think it is the right thing to do, and there's financial burden spread across everybody involved. And it's not just the providers who are administratively challenged with this. The payers are also administratively challenged with trying to respond to inquiries or, all those calls from members saying, is this covered? What's it going to cost me? So if we can automate and, leverage technology to improve those processes, I think we're going to get somewhere. And I think, you know, everybody's trying to retain their patients and retain their members, and having better information available is one way to do that.
Good point. Good point. I think that's maybe touches on another question that we got from our audience today, and that's related to how do we ensure that the patients, our members, know about this and that they can better understand what is a copay, what's a co-insurance, what's a deductible mean. Um, it's there's a certain level of literacy that we're maybe anticipating here that might not exist. I mean, I know that both probably all four organizations represented on this call today do a lot of industry education, but it might be most focused on our provider community. Um, but I think efforts like this can bring it to the patient as well because the benefit is so potentially so extensive or so impactful for the patient. No, we talked about patient financials and how this is a key component of the requirements that we've made and edited and changed. But I think something that all of us have probably talked about, and Laura, your comment in particular brought to mind that it can really impact that relationship that the provider has with the member because they're able to direct care differently, more expeditiously. They'll know if the prior authorization is required, so they can launch that, initiate that right away. And if we think about what's coming with EPA, this could all be kind of a streamlined, automated process. One button for eligibility comes back for an EPA. Yep, EPA is required. Another button that EPA fires off comes back immediately. All of this within, I'm going to say within 20 seconds, and you can understand the cost for the patient, the prior authorization's been approved, and now the drug can be administered all in the same office visit instead of today. That's probably over weeks, if not months of time to get that one simple procedure approved through PA. Sorry, I'm a little
And
uh, thinking.
no, I'll segue from that and I'll brag for a minute because pharmacy has been doing that. We started with real-time claims. We've got electronic prescribing. We have that real-time prescription benefit standard that we've built that's been named in regulation, where we're seeing, hundreds of millions of those transactions occurring every year. And it does come back and it indicates if there's an alternative product, if prior authorization is available. The EHR system vendors have built that technology and integration into play to say, oh, do you want to start the prior authorization? And it is that one button click to start that PA process. So it's all happening in close to real time. And again, it's all about speed to therapy, speed to treatment. How soon can the patient get the care that they need? And how can they do it in the most cost-effective manner for everybody involved?
And I see this also having the same type of impact for dental procedures.
Absolutely.
Oftentimes, when you go to the dentist, it might be not just your cleaning, but if you have actual an urgent care that needs to be the patient needs to be seen, and trying to understand those costs and the impacts. And prior authorization also impacts dental too. It might not be something we're really that much aware of, but it does, right? There's certain things that and benefit structures there. I'll let Rebecca and Christina maybe speak to some of those challenges that this rule will actually help.
Yeah, I mean, I think probably because it's on top of mind because I've been dealing with it so much recently, but for medically necessary dental, right, where you have a patient in your office who's going through head and neck cancer, and they have to get a clearance of infection prior to their their chemotherapy or their surgery that they need. Um, we have to work with our medical partners. We have to work with the medical insurance. A lot of times the clearance of infection will be covered by medical insurance, while, you know, any restoration is dental insurance. Figuring all of that out when you have to check patient portals and or payer portals and trying to figure out coordination benefits, all of that takes away from the time that you get to spend with the patient. The front desk getting to sit down and say, hey, this is your treatment plan and this is what we're going to do and this is how we're going to take care of you. Instead, they're, you know, have their back turned while they're looking things up and trying to answer. It doesn't instill a whole lot of confidence in that office. This is where this rule is going to just change. The office, I don't even think the offices realize how much their workflows can change and adapt with the implementation of this.
Great. Yeah, thank you. And again, I'm a complete optimist. I think that's why I work at CAQH, because I think we can change the industry for the better when we all work together and making sure that the data is, it's always there. The data is somewhere. Just getting it out there for the member or for the patient or for the provider to have access to it in real time just makes a huge difference in that care delivery. I know we've got any other questions? I saw another question come in about coordinating these changes with X12, and I'll go ahead and take that one. I think it's important that everyone on the call know that we do liaise and coordinate with all of the SDOs. Many of them are part of our organization. They sit on our calls. We send any edits or changes that we would like to see to the standard to them for them to review and perhaps internalize and make edits to the actual standard. We make sure that any of the operating rules that we do publish don't conflict with the standard, right? We can't break the 270, right, or the 271. It still is a standard transaction under HIPAA. So any of the requirements that we have are thoughtful, and we work with X12 directly. And also X12 is part of our board. They're an advisor to our board. So they also sit in our board as we have these discussions with our board members, both our health plans and our provider organizations and our vendors. I know we're getting close to our top of our hour here for the discussion. So I want to maybe move over to our call to action and bring up another point of question that came up from our audience today. On our call to action, we'd like to have you, Sarah, I know you can get that next slide back up. I think it's important that anyone on the call, anyone in the industry can be a core participant and work on developing the next set of operating rules. And actually, we're working on claim status right now, a really big topic in the industry. But again, understanding your role as a core participant is that we want to use kind of your insights, your perspectives, your experience with not only the transactions, but also the interactions that a member or a provider has with a health plan. Those interactions have often become a standard in the data set. So how do we wrap around operating rules to that standard to making sure that that interaction takes place as effectively and as efficiently as possible? A key component of ensuring that these operating rules get adopted is what we do, core as a body, is that as the core participants have pledged to support the operating rules, our members on our board have committed to implementing the operating rules. So you'll see those vendors are usually the first ones out the door in the clearinghouses. They'll be the first ones to tie in these requirements and get them rolling through their applications and transactions. So they'll be looking for those providers. They'll be looking for those health plans to plug in and start sharing this data. But again, those health plans are going to be right behind them because they're also interested in that core certification, that seal of approval that they're ready to go with that data exchange. And after that, we also will publish pilot information and data and white papers. We'll find those first vendors, we'll find those first health plans that have done this, and we'll work with them to publish an ROI study. We'll look at them to see how effective it was. How much did they really save? And I think that the numbers will speak for themselves, as they have in most of our other ROI studies, and that it will be in the millions of dollars immediately. Like within a year, any of the costs that you've taken to implement, you're usually recouped within 12 months of any of our operating rules that we've had published. And also, you'll see that the time that it takes for providers to have that interaction with the patient, if you bring that down to a transaction and a set of operating rules, it reduces the cost. And last but not least, be an advocate. The part of the process where anyone can be, and all of us as a member or as a patient can be part of that process as well. No, I don't want to speak for the other three organizations on the call, but all of them are advocating for the best process forward. And also become a participant for those organizations, become an advocate or a cheerleader for those organizations, because we're all working together to bring more of a seamless process to the industry. And with that, I'll hand the call over to Jackie for our wrap up. And I want to thank the panelists. Thank you.
Yeah, thanks, Bob, and thanks again to our panelists for that thoughtful discussion today. Before we jump off, I do want to recognize that we got a few more questions that came in. I know we are out of time, but please feel free to email us at core@caqh.org if we didn't get to your question today. We'll be happy to answer it for you. Someone did ask about the recording. If you weren't able to join the whole call today, we will be sending out a recording in the next 1 to 2 business days. And with that, I think we are all set to wrap up. Thank you everyone for joining, and I hope you have a great rest of your day.